Welcome to the podcast series Inclusive Research and Innovation in Science, Technology, Engineering and Mathematics. Inclusive research and innovation takes place whenever science, technology, engineering and mathematics scholars actively integrate the diversity of human beings in their work. In doing so, they contribute to inclusive processes and results. Yet, how do we get there? My name is Claudia Wacker, and I'm an associate professor at Delft University of Technology in the Netherlands. I host this podcast series on IRI and STEM. Guests in this series are various colleagues from different universities of technologies and other universities. All of them consider IRI and STEM principles or explore of how to do so. Today, I welcome Professor Dr. Hanneke Takkenberg, working both at the Erasmus Medical Center and the Erasmus Business School. Recently, she was one of the 3 founders of the new Center for Women's Health at Erasmus Medical Center. It is a privilege having you today, Hanneke.
Thank you so much, Claudia.
Well, please tell us about your professional background and your activities in your various roles and how you combine them.
Okay, so where do I start? Let's start at the beginning. I was trained as a medical doctor in Groningen and Amsterdam, and then moved abroad for a couple of years to the US and did some clinical work in heart failure and heart transplantation at Cedars-Sinai in Los Angeles. That's where I had my first child, and with my first child under my arm, as we say in Dutch, I moved back to the Netherlands, to Rotterdam, where I started working in Erasmus University Medical Center in the Department of Cardiothoracic Surgery. And I've been working there all my life. In 2012, I became a professor of clinical decision-making in cardiothoracic interventions. And I've been building my career on themes like clinical decision-making, but later on also shared decision-making, and also far more interest in sex and gender in the context of cardiothoracic interventions. So are there different treatments for men and women? How does that work when a patient is diagnosed? Are different treatment options offered? Do they have different outcomes? So that has already been a red thread in my career. On the other hand, I've always been very actively engaged in the Erasmus MC in trying to create more equitable workplaces, in particular for women. Although 70% of employees in the Erasmus MC is a woman, there is a severe underrepresentation up until today in higher functions. It's getting better, but we're not there yet. And from both a social justice perspective and a perspective of that our organization will become better at serving our patients and advancing science, I've always been a strong advocate for gender equality. Through that role, I also started working 5 years ago at Rotterdam School of Management. I am the executive director of Erasmus Center for Women and Organizations, and we try to implement gender equality and gender equity and inclusion in any organization through research and through very fun education and interventions. So that's what I've been doing for the past couple of decades. And from one thing came the other. And earlier this year, indeed, I am one of the founders of the Netherlands Women's Health Research and Innovation Center at Erasmus MC.
Could you tell us a bit what you will be doing with the new center?
Oh, absolutely. This new center, perhaps I should also begin there last year when we came together for the first time to start talking about working together on women's health in the Erasmus MC. And you should know that in the MC, as in any hospital, all specialties are basically divided in, I guess, in an organic way, meaning that, heart doctors work with heart doctors, gynecologists work with gynecologists, and it's quite siloed. And very often we do not meet each other on themes like women's health. So early last year, the World Economic Forum was actually, for me, a big reason to get engaged with my colleagues outside of my own field. The World Economic Forum report mentioned the global health gap there is for women. And I think for me, the most important thing I noticed was not only do women live 25% longer in bad health compared to men, but it's also costing society and economy a lot. If you look at it globally, it's $1 trillion. If you look at the Netherlands, it's annually 12.8 billion euros that we are missing out on because women live in poorer health. Because they live in poorer health, not only is it bad for them and for their quality of life, also they're far less productive. And also, if you don't feel too well, you're also not able to care optimally for the people around you. And for me, it was that made me go to this session in June last year that was organized by our Research and Development Office, and where with about 60 of my colleagues from all kinds of specialties, but also both scientists and clinicians, we started the conversation about working together on women's health. And that took a bit. But our board of directors was supportive, and because they had just started an outpatient clinic for employees who are in menopause. And they found out that by having this outpatient clinic, by helping their employees to feel more healthy, of course, what would happen, not only would these women feel more healthy, but they would become more productive and more able to function at work. So that was one of the reasons as well from our board of directors. Then in December, we got together again and our group had grown. All of a sudden, there's like 80 to 90 people in a room, all wanting to participate and getting to know each other. And not only from their own specialty, but also to see how they can work across specialties. And that was very special. And I should say that my co-founders, Janine Roeters van Lennep, who is an internal medicine doctor at the Erasmus MC, and Greet Vink, who is the director of our Research and Development Office, and also the director of the Smart Tech Health Center here at the Erasmus MC, were crucial for this. The three of us, I'm a scientist, Janine is a clinician, and Greet is really somebody who knows how research works. We cooked up together with a team of people that were there at our sessions a strategic agenda and came up with a beautiful strategic agenda. So I'm happy to tell you a bit more about the agenda of our center.
Yes, please do. I would be particularly interested because you are, of course, focusing in your clinical research on heart diseases, if I'm not mistaken.
Yeah.
And if you are now working together with other disciplines, what is popping up immediately as a kind of common denominator, which is popping up? Perhaps menopause or other kind of phases of women's health or other issues. What is immediately popping up as problems?
Well, it's good that you ask, because if you look at the focus on women's health and the funding for women's health, you see that there's very little focus on funding women's health to start with. And the focus is usually on diseases that are quite lethal, such as cancer. However, there's hardly any attention on those diseases that have a high burden in daily life. Chronic diseases. So if I can give a couple of examples from the World Economic Forum report, menopause is in first place. Then there's the menstrual cycle. Then there's conditions like endometriosis, like PCOS, a couple of gynecological conditions. Then there's heart disease, but also migraine, depression, and other mental disabilities are there. And there's hardly any funding for innovations and for research going into that direction. So that's something that we found very important. And when we built our strategic agenda, we said we need to have focus on those conditions where we can have the most impact, not only quality of life, but also on the gross domestic product. So these are the conditions we focus on. And then there's, of course, a risk that when you start a women's health research and innovation center, that you're only going to talk about women-specific disorders. Of course, they're important. But next to that, and it's actually the first objective that we have, is women-specific disorders that have to do with our reproductive organs or with our breasts. But next to that, we specifically have a second aim, and that is about chronic disorders, chronic conditions that affect women disproportionately or that are really not very well recognized in women. And there's where heart disease comes in. We all know the stories about women who more often complain about being tired and having different complaints than men and not having recognized that they're actually having a heart attack. It's just one of those examples. But there's more. Also, the third aim that we have is that we look at the women's life cycle. So all the stages in life with a particular focus on productive life. Because in productive life, when you study, when you work, and there are conditions that really affect your productivity, that's something that we need to address as well. Fourth, another important one is the data gap there is for women. For example, we register for every patient's height, weight, more general aspects of patients, but only our gynecologists are actually systematically registering in our patient information systems menstrual cycle, menopause, birth weight, these type of things. And then there's, of course, the bias there is in the data that's already around. That's providing us with AI being really taking a leap. It's a big problem. If we don't do anything right now by getting in female-specific data into our data sets, we're lost, basically, because the data has not been collected in the past. And AI is going to work with it and is going to come up with solutions that are aimed at men and not at women. And women are not small men. I mean, they're way different.
Very interesting. If you would have to envision the kind of coolest results to achieve regarding diversity and inclusion in your line of work, in your research and innovation, what would that be?
The coolest results?
Yeah. What would make your heart sing, let's say, in 5 or 10 years, that you would say, well, we did it?
Well, I think the most cool thing would be is if we can offer women a healthy life at a much earlier age. I think the impact on aging, on how we age, and how we will be able to lead healthy lives later on in life will be tremendous. And for me, that's the most coolest thing. Of course, that's a very big goal. The other one I think has to do with the data. And that's something that's really close to my heart, is making sure that this data gap disappears. Because right now, due to this data gap, women are still being overdosed, are not getting the treatment they need. And we see that therefore the outcomes of women after interventions, for example, can be much worse than for men. Also, what I think would be truly cool, and that's my third cool thing to say, is if we can definitely establish sustainable scientific relationships between the different disciplines. So, for example, my colleague Janine Routers van Lennep, she has an outpatient clinic where she sees women who had problems during pregnancy. If you have problems during pregnancy, not a lot of people know, not a lot of gynecologists are aware yet that women who have high blood pressure or even worse symptoms of high blood pressure during their pregnancy are at a very high risk of developing heart disease later on in life. However, right now, these people go through their pregnancy and because they're being monitored during pregnancy, have a relatively okay pregnancy, but they're not being referred to the cardiologist to start preventive measures against heart disease. If we can make those links between disciplines, I think that the effects would be enormous. That would mean that early on in life, you have preventive, easy measures that make sure that later on in life, you do not run into things that are so avoidable. And right now, we have a lot of women that face this. So it's placing the link between...
Yeah. I come back to your data question later, because that is something that is always recurring in these kinds of interviews I'm having in this podcast series. But I'm very intrigued by what you're saying about longer life and a longer healthy life for women, because my impression, but that might be wrong, is that the higher the income of women is, or the more educated they are able to sort of make that happen for themselves. Perhaps not perfectly, as you would be able to do for your patients, but at least they can sort of navigate that. While women with a lower income, lower educational background, they might struggle much more with this. Is that something that resonates with you?
Absolutely. Well, and specifically in a city like Rotterdam is one of the focal points of what we want to achieve, to have equitable access to healthcare, but also empowerment of people to being able to receive the treatment they deserve. And so this is also at the heart of what we do. And that also brings me back to data, because we don't have that much data about it. And that is problematic. And especially if you look at the more cultural aspects. For example, if I think of an area where we can have really a lot of improvement in closing the health gap between those who have and those who have less, as I call it, I think that also lies in collecting the data about it. We do not have that. And on top of that, I think, of course, if you're rich, you can go to any pharmacy and buy any supplements if you suffer from menopause. But that's also not what we want, because women are spending, we know that women are responsible for 80% of consumer spending, and a considerable proportion of their spending is into supplements and other types of alternative treatments, because there's no good treatment for the conditions that they suffer from, because there's no evidence on how it works and how you can best treat it. So I think regardless of your socioeconomic status, it's important that we start addressing that there's more evidence on the effectiveness and also more medications to help women. For example, through menopause, for example, to help you alleviate the symptoms of your menstrual cycle. There's some great innovations coming along there. That's what I see if I go to all these different femtech innovation events that are all over the place right now. But we do need to work on the evidence for that. And we do need to raise awareness also, not only on generating that evidence, but also making sure that clinicians pick up on it. And then there's something else as well, is, for example, if you talk about menstrual cycle and menopause, there's quite of a taboo. And that taboo is definitely there among women. You know, talking about your menstrual cycle and menopause are things that only recently in society you see some movement there, in particular in those groups of people who are highly educated and feel now more free to talk about it. But also your GP needs to talk about it. And also the medical specialist, other than the gynecologist, needs to start realizing that these cycles have a tremendous impact on women's health. There was a great example, if I can give one example, of a conversation that Janine had with an anesthesiologist in the Erasmus MC. And she talked about the menstrual cycle. And he's like, oh my God, you're right. We never ask our patients about menstrual cycle. But these are people who are actually making sure that operations can take place safely. So if you don't talk about it, if you don't register it, you're not going to learn from it. And perhaps it's not wise to have a big operation while you're menstruating. One thing. Another example is this example of this young woman who visits our outpatient clinic, and she has anemia for a long, long time, and she's taking iron supplements for her anemia. Nobody ever asked her about her menstrual cycle. She could hardly go to school during the week that she had her menstruation because her bleeding was so heavily. Nobody ever asked her. They just gave her iron supplements for her anemia. Only at the point in time where she was diagnosed with having a rare blood disorder causing severe bleeding during the menstrual cycle could she really be helped. So it's also about deepening our knowledge and raising awareness that we need to talk about this and that we need to implement it in our research, but also in the innovations that we make.
So basically you're saying we need more data, which of course comes also with questions about how do you ethically and also privacy proof store this data, use this data. But you are also calling for a lot of interdisciplinary work really between medical disciplines, possibly also technical disciplines, because of course here at Delft University of Technology we help a lot of your colleagues, for example, with surgical instruments and the like, which might also be something that is of interest. I interviewed a couple of months ago someone who was making surgical instruments and who was really convinced that they could not consider the diversity of human beings until we asked them, well, women on average have much smaller hands. What do you do about it? And they came back to us afterwards and said, we put that to work and we have a prototype now, with which the female surgeons are much happier. So there are all kinds of aspects that you can only solve, and I completely agree with that, if you work across disciplines and don't have these silos. But if I understand you correctly, in your specific line of work, it's first and foremost looking towards other medical disciplines and see what does it mean, disorders of the menstrual cycles, menopause, what does that mean for other kinds of diseases like heart diseases, but possibly also other diseases?
Well, I think you're right, but I would like to go beyond interdisciplinary. Interdisciplinary, one of the examples we have here is Natasja de Groot, who's working closely together with the colleagues at Technical University Delft, taking a look at cardiac arrhythmia and also exploring the differences between men and women. And there you see it is technology and it's medicine combined. And we have many more colleagues who work also with the technical universities. And I think technical innovation is crucial in order to really make a big change and close that health gap for women. On the other hand, I also believe social innovation is of the utmost importance. So we also need to start working with other stakeholders. We need to start working not only with the social scientists, we need to start working with the women of Rotterdam. We need to start working with the city, and we need to start building an ecosystem where we all learn from each other, because the expertise we have is really complementary. And the fact that we do not meet often enough is a bit worrisome. And that's something we would like to change as well. So what we envision with our Netherlands Women's Health Research and Innovation Center is to boost research and innovation in an ecosystem in the direct vicinity of the Rotterdam area. So that includes Delft, but also includes the university, and it includes innovators who are really aligning with what we are good at in the Erasmus MC as well. And patient organizations and women's organizations that are advocates. So we take really a transdisciplinary approach where we all, we all bake a really big pie together. And it will be, I think, really tasty, the product. And I hope it will really help the lives of women, but also improve inequities. Because can you imagine that if we work together with the women of Rotterdam Zuid to improve their health, the tremendous impact it will have on their direct environment, on their productivity, and not in the last place on their quality of life. I think it benefits everybody. And it will also benefit their husbands. I think they will live longer and happily, more happily than ever. So,
happy wife, happy life.
That's right. That's the saying. Yeah.
But I'm really intrigued that you are also reaching out to communities of, let's say, like Rotterdam South, where you have communities that are quite different regarding income, education, also culture, because I can imagine that this is a rather big challenge to even earn their trust, that they share their experiences, give their data to you, in order to make all that happen, what you are just describing.
Yeah, and I realize that it is challenging. On the other hand, there's some really great social innovation initiatives in Rotterdam Zuid that we can really learn from. And so rather saying, well, we need to go out there and help these poor women. I don't think that's the way to go. I think we need to build coalitions and learn from each other. And I think we have a lot to learn from some of those initiatives in Rotterdam Zuid. For one of those, I love them. It's called Women Connected, and it's a theater group, a social innovation theater group that actually puts women from Rotterdam Zuid on stage and makes them do theater productions. And through their social innovation, a lot of things are happening. And you see that same as technological innovation can make a big difference, but the social innovation is really changing the behavior of people and of the community, and has a very positive and empowering effect. So we should not underestimate it. I always say we need the balance between technological and social innovation, and if you bring them together, you have magic, and I hope that's what's going to happen.
Well, you have convinced me, or I could even say you are preaching to the choir, but let's hope to convince others as well.
Yeah.
Given our conversation, is there anything you would like to share with us that you didn't have the chance to share with us before?
Well, what I hope on the longer term, and I think I see it happening a little bit, is that our initiative in the Erasmus MC will also happen in other institutions in the Netherlands. What I hope for is that we called ourselves the Netherlands Women's Health Research and Innovation Center, not because we want to be the only one, we just want to be one of many of these centers across the Netherlands. And hopefully we can connect those centers. We call it a coalition of the willing, where we can basically build learning communities, but also cooperative communities where instead of competing with each other, we reach out to each other and learn from each other and work together on women's health. Because this is such a big issue, it's not something that we can let go right now, especially in these times, tough times when it comes to women's rights and to a lot of rights. I think for me, it would be great that in 10 years we actually have a network of ecosystems in the Netherlands on the theme of women's health that is cooperative. And that includes not only university medical centers and technical universities, but all kinds of other stakeholders. That's
I
what
would be even more ambitious, and I know that you have a workshop coming up in Brussels, so I would hope for these kinds of centers all over the EU and even better all over the world. So let's see, in 5 years or 10 years, perhaps we pick that up again as a topic for another podcast and see how it worked.
Yeah, and I think, well, next week we're going to Brussels, and one of my colleagues has already been there last week, and we're very hopeful that in Brussels we can share our experience in the Erasmus MC that was really transformative by initiating interdisciplinarity in what we do. And we hope that that's may help also to shape the ideas towards the future. And then, if you're really ambitious, I would love to have it in all of Europe and the rest of the world, as far as I'm concerned. But we need to start with ourselves and an attitude that is about cooperation, about working together with people you're not used to work with. But once you start working with them, there's so much energy. That's what we are experiencing. It is really a lot of fun. And we're more productive than ever when it comes to getting this research and the innovations going.
Well, we can always dream big, and let's see where it takes us. Thank you once again for contributing to our podcast series on inclusive research and innovation in science, technology, engineering, and mathematics.